Good morning, everyone. Good morning. All right. Well, it's great to be here. Thank you for having me. So like Matt said, we're going to talk a little bit about mechanical ventilation, just what the emergency provider needs to know. When I was a third-year medical student, I became very interested in the ventilator, largely because I was very intimidated by it. And when I was going through residency, I realized that some of the intimidation came from the fact that we're largely taught by intensivists. Some of you guys may be intensivists, not all of us. The emergency provider does not need to know what the intensivist needs to know. So I started this lecture back when I was a resident, and it's now turned into an iteration that I give the residents periodically. It's about a 3-hour lecture, but I've got you guys an hour version of it. So, the airway is really the sexy part. That's the thing that everybody gets really excited about talking about, right? Once you put the patient on the ventilator, disposition's done. We're going to focus on the patient. The respiratory therapist is going to really manage the ventilator. So that's kind of, from a mechanical ventilator perspective, that's really where our management stops a lot of times. And if you supervise residents and they're doing your airway, that first time that you push a paralytic and you have to step back, let somebody else take over, and they're successful, you look a little bit like this, right? So, airway's done. We've got it. Disposition done. All right. But really, we need to be looking at this and focusing in on actual ventilator management and making sure that what the respiratory therapist is doing is right? So really, at least in a lot of cases, emergency department, respiratory therapists are the only one managing it, like I suggested. But we need to be watching each other's backs, okay? So our goal today is to not lose the forest for the trees. And that's where we get confused. There's a lot of details with the ventilator that we really don't need to know. So I'm going to water that down, and we're going to keep it simple, all right? And I'm going to give you some tips on how to avoid getting in a bind. But if you find yourself there, give you some ideas on how to get out of a bind, okay? So why should we care? Well, boarding is becoming a bigger and bigger problem every single day. Some of those patients may be mechanically ventilated. So we need to be able to make sure those patients are being appropriately ventilated and be able to troubleshoot the vent if the problem arises. In some smaller centers, emergency physician may be the off-hours intensivist. So we may have to actually go to the intensive care unit and troubleshoot a vent, and then be able to have a conversation with that intensivist if a problem arises. Respiratory therapist isn't always available, and as I suggested just a second ago, they're not always right. We need to be watching each other's back. And there's some evidence-based protocols out there that really saves lives, and that's, at the end of the day, what the business that we're into doing, right? The mechanical ventilator, like I said, there's a lot of details, and it's confusing, right? But if you water it down, at the end of the day, it's just a pump, right? It is just a pump. It's a complicated pump, all right? But it's got its piston, and it's got its pump cylinder hooked to a computer that's going to infuse oxygen and monitor exhalation and inhalation, right? But really, again, at the end of the day, it's just a pump. And there's a couple of simple strategies, as I've hinted multiple times, that can help you navigate that pump. When it comes to the strategy that you're going to deploy, you have to ask yourself, well, why did we intubate the patient in the first place? A lot of times it's going to be poor oxygenation or type 1 failure, perhaps poor ventilation or type 2 failure, and then the decreased work of breathing or airway protection, which really can be blended in with these two, but I set them aside because they also can be independent problems. We're going to focus first on the type 1 failure, poor oxygenation, okay? But this strategy also applies with the work of breathing or airway protection patient. So the lung injury strategy, this is obviously the things that are turning our lungs white, right? Pneumonia, pulmonary edema, aspiration, ARDS, pulmonary contusion, atelectasis. The goal of our strategy here is to recruit alveoli, right? And once we've recruited them, we want to prevent DERECRUITMENT. We also want to protect those alveoli, right? We're going to do that with our typical mode settings, or excuse me, our ventilator settings. I'm going to save mode for last because, in my opinion, based on my years of doing this, the mode is the most confusing portion, really, of the ventilator. So let's focus first on tidal volume. And when it comes to lung injury strategy, the tidal volume is where the money is. In the old days, and I use quotations because the old days really would have been in the 90s, we would be using 10 to 15 cc's per kg of true body weight. And that was working off the notion that the bigger you are, the bigger your lungs must be, right? So if you look at this fella here, he would have gotten a larger tidal volume than this guy. But really, it's about predicted body weight. And predicted body weight comes off of the patient's height, right? So this guy actually needs the bigger tidal volume than this guy, okay? And then there's this. Well, we just talked about lung injury, right? That's the strategy that we're talking about. Here we have a pleural effusion. We have some interstitial edema. We have some infiltrate. We have a lot of alveoli that are not accepting tidal volume because they're collapsed. Then we have a few alveoli that are still open and accepting that tidal volume. Well, if you're giving full tidal volume, what you and I would be breathing right now, to those few alveoli that are still functional, we're going to damage those alveoli, right? And you're going to create something called ventilator-induced lung injury, or VILI, as we call it for short. Barotrauma is kind of the macro version, right? Pneumothorax, mediastinum. Volutrauma is kind of more on the microscopic level, as well as the biotrauma. So volutrauma, overexpansion of the alveoli. The biotrauma is the creation of the inflammatory mediators. And then atellect trauma, that's the opening and closing of those alveoli as we deliver breaths and exhale. And that's really more managed by PEEP, so that's why I grade that out. Now, the Arsenet guys started to figure this out in the 90s and published a landmark study, 2000, New England Journal, 861 patients, multi-center. They did 12 cc's per kg predicted body weight to maintain a plateau pressure, and we'll talk about plateau pressure if you're not familiar with that, less than 50, versus the 6 cc's per kg predicted body weight, plateau pressure less than 30. These were very sick patients. They had ARDS per the definition at the time. The study was ultimately terminated early because there was a 9% difference in mortality between the intervention group, which was 6 cc's per kg, versus the control group, which was 12 cc's per kg. And also there was more ventilator-free days for the intervention group, 68% breathing ventilator-free by day 28 versus 55%. Now, since then, there's been multiple studies, and you may be thinking, well, not all of my patients, most of my patients, if not all of my patients, don't have ARDS, so does this apply to me? Actually, there's been multiple studies since that show using this same strategy, low tidal volumes per predicted body weight, is going to prevent the development of ARDS. And I think we can all agree that's a good thing, right? So, in terms of setting the tidal volume going forward, 6 to 8 cc's per kg predicted body weight, all right? That's the tidal volume that you want to target. Now the question comes, how are we going to calculate the predicted body weight? I think there's a lot of reasons people kind of forget about doing it. There's equations for this. I actually keep a table in my phone that I'll show you here in just a second. It's very easy to look it up on Google. In terms of estimating the height, I'm not really good at standing back and trying to get an idea of how tall the patient is. So just keep it in the back of your mind, the ED mattress is about 75 inches long. All right? Your index and middle finger spread apart, maximal is about 4 inches. So you can count back from the base of the bed all the way back to the patient's foot. All right? And you can get a rough estimate of how many inches they are, apply it to your table. All right? This is the Arsenet table. And here we have height in inches, and then they put it out for you, 4 cc's per kg predicted body weight, 5, 6, 7, 8, on and on. I know you can't see this, so I'll read it out for you. These are highlighted average heights for males and females. So for a male, if you can't read it, this would be 438 mLs, 511 mLs. On average, males are usually, my experience has been, they're usually default to 500 mLs if you watch your respiratory therapist. And that would be fine. That would be fine. We'd be right at target. Whereas look at the female here. Average height right here is 328 to 383 mLs. So we're generally overshooting on the females. I've noticed that usually the RT will default to 450 with a female. But I think that we're overshooting. So it's something to keep in the back of your mind. Once you set your tidal volume, that 6 to 8 cc's per kg predicted body weight, we're going to monitor the airway pressures. Right, airway pressure being flow times resistance plus alveolar pressure, and this is where the money is, the alveolar pressure. But I still think that the airway pressure is useful Understand, though, the airway pressure, or peak pressures particularly, is not extrapolated out to harm to the patient. Those peak pressure alarms that are going off does not necessarily mean that the patient is getting harm. I think it's still a useful number, and I'll show you why. First off, where is it? Usually it's going to be located on the screen. This will be one of the larger numbers. You'll see P peak, okay? In this case, this patient's peak pressure is 18 centimeters of water. Why is that helpful? Well, let's take a look at what plateau pressure is. Plateau pressure is the pressure throughout the circuit and the lungs when flow goes to zero. So we pause ventilation at end inhalation. So we do a inhalation pause, and you're going to get your plateau pressure. So this zeroes out. All that is left is your alveolar pressure. You get a plateau. This is the one that's associated with harm to the patient. Above 30, you are potentially harming the patient, increasing their likelihood of getting ARDS. So, the peak pressure will never be lower than the plateau pressure. So, you're not having to go to the bedside and hit plateau or hold, right? Having to breath hold the patient to get that plateau pressure. Just look at the peak pressure. If the peak pressure is less than 30, the plateau pressure is less than 30. If the peak pressure is above 30, you do need to go ahead and do that plateau pressure. So either you could do it yourself, or you could have the respiratory therapist come by and check it if you're worried about doing it yourself. It's very simple to do. It's just a button that you hit. Okay? So this is how you can monitor your plateau pressures, by really watching your peak pressures. Okay, so moving through tidal volume, and that's the hard one for lung protective strategies. Long-winded presentation just to say 6 to 8 cc's per kg predicted body weight, and we're going to follow our plateau pressures indirectly by watching our peak pressures. Respiratory rate, well, don't get worried about equations or anything like that. I just put it up there to show, really it comes down to your minute ventilation. The normal healthy subject is 5 to 10 liters per minute. If we start working really hard, it may be 40 liters per minute, 50 liters per minute. Really, the question is, what's the respiratory rate that we need to maintain a CO2 that then maintains a pH that's acceptable with life, right? Well, we already know the tidal volume that we're set, right, because we just set that. So we'll plug that in. We can rearrange our equation. So let's say we set 5 liters. This is an average-sized male, and we just want to ventilate them at a normal minute ventilation, 10 liters per minute. That comes out to 20 breaths per minute. So are your RTs starting around 14, 16, right? That's where so usually we're hypoventilating that patient, especially when you add on the dead space of the tubing, right? And it really goes beyond the valves. Or this is not really counted, it's after here, right? So this Y piece and your ET tube, that's added dead space. So if you're setting your mechanical ventilator much less than 18 or 20 breaths per minute, you're probably hypoventilating that patient. Remember, they usually are going to have a higher minute ventilation to begin with when you're intubating. They're usually working hard to breathe for some physiologic reason, right? So in terms of setting the rate, before I tube the patient, get a good idea of what their rate is. That's a good marker, probably where you should start. They're breathing at a rate of 25 or 30. You should probably start there until you figure out what's going on with the patient. And then you can track your pH, right? We're not going to worry about making the patient euthymic, because you could actually harm the patient. Think about if you make a patient with a severe lactic acidosis or DKA or chronic respiratory acidosis. If you make them euthymic, you're going to create an acid-base derangement that could be harmful to the patient. Now, I say use their pre-intubation respiratory rate as a guide. There's a limit with the ventilator. You'll start breath stacking once you start getting them much above 35 or 40. So top end for me is around 30, 32, something like that, depending upon if they have baseline lung disease, specifically COPD or asthma. All right, so 18 to 20 to start, and then track our pH with a gas. In terms of FiO2, another equation that looks really complicated, but let's hone you in right here. I want you to focus first on the PaO2 and its contribution to oxygen delivery. All right, so if you actually did the math on this, if we had a PaO2 of 500, that'd be 1.5 mLs of O2. It's a very small contribution to your oxygen delivery. So really, you could take that out of the equation. Your PaO2 is really not useful in terms of oxygen delivery. Oxygen delivery is really about cardiac output, hemoglobin, and your oxygen saturation. So in those patients that you're running them with a PaO2 of 500 and 600, are you really contributing anything to oxygen delivery for that patient? You're not. You're absolutely not. Potentially causing harm, right? Because you have all these oxygen-free radicals that are going through the bloodstream. There's actually some evidence to suggest that there's worse outcome in post-cardiac arrest patients who are run hyperoxic. Okay? So our goal is to get that PaO2 down less to 120. 120 would be about 100%. You start going down, a SAT of 90% is a PaO2 of around 60. So somewhere between 60 and 120 should be your target. Much above that, potentially causing harm to the patient. Now the other thing to know, this is our oxygen hemoglobin dissociation curve. Here's PaO2 plotted on the x-axis, hemoglobin saturation on the y-axis. And you can see here, what is that, roughly, I don't know, 95. We have a SAT of around 98. So you can see on this top portion, the flat portion, there's a big range in our oxygen saturation. So that patient who has a SAT of 100%, they may have a PaO2 of 700. They may have a PaO2 of 120. All right? But as you start to get to that descending limb, you can see there's big changes in our saturation with small changes in our PaO2. So if you're running the patient somewhere in here, you're going to start to know if they're getting worse. Whereas if they have a PaO2 of 700 and they start to develop lung disease, they've got a long ways to go before you're going to notice it in the saturation, unless, of course, you're doing serial ABGs, but people probably aren't doing that in the emergency department. Also, there's really no evidence that a saturation much above 95 is really a benefit to the patient. So if you are reaching a goal, or if you have a SAT of 90, 95%, you are fine. Leave the FiO2 alone. Okay, leave the PEEP alone. The patient is doing fine. There's no benefit, with the exception maybe of a patient who's having an MI, or maybe they have poor lactate clearance. Really no benefit. So SAT of 90, 95 is a nice goal. And we're going to work to get our FiO2 less than 60%. Okay, so I'll start out at 100 for the first couple minutes after we've placed the tube, and then quickly come down to 60% if I can. If it's particularly with the reactive airways disease strategy, which we'll talk about shortly, maybe just come down to 40, because they don't have an oxygenation problem, right? They have a ventilation problem. If they're hypoxic, I do the best I can to get the FiO2 to less than or equal to 60% by utilizing PEEP, which we'll talk about right now. So again, setting our FiO2, SAT greater than or equal to 90%, with the goal of getting our FiO2 to less than 60%, and we're going to utilize our PEEP to do that. All right, so PEEP is really about preventing derecruitment. By putting that patient on the ventilator and giving a positive pressure breath, we're going to snap open a lot of alveoli that were closed before we intubated them. But we want to keep them open. We don't want them closing it open, closing it open, closing it open, right? We want them to stay open, and that's where PEEP comes in. It's going to improve oxygenation because we have more alveoli that are staying open to participate in gas exchange. It's going to improve lung compliance, right? Because we got more little balloons open that are accepting air. So our lung compliance is going to go up. And we're going to reduce the adolect trauma that we talked about, hopefully preventing ARDS. All right, so here is an airway pressure curve on our ventilator. You can see that when they fully exhale, have an airway pressure of 0. What we're going to do is shut the valve, the exhale valve, a little early and maintain a pressure of 5. You and I, as we're breathing here, we have a PEEP of around 2 to 3. So a little bit of PEEP is physiologic. All right, so we don't have a PEEP of 0. So those of you that may be running the PEEPs and the zeros, that's actually anti-physiologic, right? Here's what it looks like on a video. This is a porcine lung model. They have a tidal volume of 700, a PEEP of 0 on this side. And look at all that recruitment and then derecruitment of all that volume loss. Think about the pressure that it's requiring too to snap that lung open and then it comes back down. Snap the lung open, comes back down. Whereas here we have a tidal volume of 400 and a PEEP of 10. Nice, open, highly compliant lungs, ready to participate in gas exchange. All right. Well, are we doing harm by running high PEEPs? Well, this was a study done by the ARDSNet group in 2004, and they compared a low PEEP to high PEEP protocol. The bad news is there really wasn't any difference in outcomes. The good news is there wasn't really any difference in outcomes, all right? So it depends on how you want to look at that, all right? Those of you that are worried about running a PEEP much more than 5, it's okay. It's okay. Look at how high the PEEPs, right here. They had all the way up to 24 on the high PEEP protocol, all right? So don't be afraid to run the PEEP up a little higher. And these tables are available on the web. There is another one that I keep in the phone if I'm really having a difficult time oxygenating a patient. If I have an FO2 of 100, but they're satting 85 and their blood pressure's okay, we may play with the PEEP a little bit and see if we can optimize them. PEEP is also used for some recruitment maneuvers. It's a little bit beyond the talk today, but you can talk to your respiratory therapist about that. So what I do is I'll start with a PEEP of 5 and I'll work to get the FiO2 to less than 60%. If I can achieve FiO2 less than 60% with a PEEP of 5, I'm feeling pretty good. If I cannot achieve an FiO2 of less than 60% with a PEEP of 5, I tend to run the PEEP up a little bit, 8, 10, 12, to see if I can get that FiO2 down. All right. Caution with a patient who has elevated intracranial pressure, right? Because we're going to maintaining positive intrathoracic pressures. It's going to affect blood return from the brain, so it may run intracranial pressures up. The hypovolemic patient, right? The patient who has poor preload, blood is fighting to get back from the lower portion of the body back to the right heart. If we have a bunch of positive pressure in the chest, that patient may become hypotensive. Also the right heart failure patient, because we're increasing afterload on the right heart. That right heart, the right heart is a thin-walled structure compared to the left heart, so it can't generate a lot of pressure. So be wary of that as well. Bottom line is if you're running the PEEP up and they're becoming hypotensive, you got to back down. Okay, that's the take-home point. Respiratory flow rate. That's the rate at which we're going to deliver the inhalation component of our breath. In terms of the lung protective strategy, not terribly helpful other than to say, generally it defaults to 60 liters per minute, all right, but it can go up to 120 liters per minute. It's not terribly helpful. I don't really consider this a whole lot in that lung protective strategy, other than maybe if the patient looks really uncomfortable. But our patients in the emergency department, they generally are very uncomfortable, right, because they're sick. So I think rather than playing with the inspiratory flow rate to make the patient more comfortable, I think probably a little better analgesia or sedation would be the better thing to consider. So I don't worry about the inspiratory flow rate in this case, but I wanted to present it to you now. So the lung protective strategy, again, the big one, 6 to 8 cc's per kg predicted body weight, follow our plateau pressures through our peak pressures, respirate at 18 to 20 and track our pH. FiO2, we're going to set a goal to get our FiO2 to less than 60% and not worry about it if our SATs are 91, 92, 93. That's okay unless it's an MI or a patient who's not clearing their lactate very well. We might run their SAT up slightly higher. PEEP of 5 and titrate, again, to get our FiO2 less than 60%. And our inspiratory flow rate default is fine. I wouldn't worry about that. 60 liters per minute. Now, moving on to the patient with reactive airway disease, that patient who can't get air out. It's that poor ventilation. And obviously, they're working hard to breathe, right? We're going to alleviate their work of breathing. So these two blend together nicely. Well, why do these patients get intubated? I just said it. Because they're working hard to breathe. They've got all this, like, just imagine sitting there, take a big breath in, and now try to breathe on top of that. Try to get another breath in on top of it. That's what it's like living with a severe asthma exacerbation or severe COPD. But it's kind of counterintuitive. Now we're going to force more air in there. How are we not creating a problem? Think of it from the perspective of reducing work of breathing and giving more time to let that air get out. Right? So, very simple in terms of tidal volume. It is the same. 6 to 8 cc's kg per kg predicted body weight. Right? And we're going to follow our plateau pressures. This is one where you have to know the difference between your peak and your plateau. Your peak pressures are going to be very high. there's a lot of downstream resistance because the lungs are overinflated, right? But as long as your plateau pressure is less than 30, and this is the one where you're going to have to keep doing plateau pressures, have the respiratory therapist agree to come by and check that frequently for you if you're not doing it, and make sure those plateau pressures are less than 30. And if they're less than 30, then you're doing good. Now, one little caveat here too, the machine will alarm when it reaches a certain peak pressure. That may be 40, 45 centimeters of water. You may have to increase your peak pressure alarm, okay? The respiratory therapist can help you with this, all right? They're gonna keep coming to you, so the peak pressure alarm's going off, peak pressure alarm's going off, peak pressure alarm's going off. Well, let's turn the peak pressure alarm up. Turn the trigger up. As long as the plateau pressures are okay, you're okay. Where the money is with the obstructive lung strategy is with your respiratory rate. Let's say that we, like with the lung protective strategy, set our rate at 20 breaths per minute. We're taking a breath every 3 seconds. So our IDE is 1 to 2. 1 second to get the breath in, 2 seconds to get the breath out, right? If we lower that to between 8 to 12 breaths per minute, let's say, for example, 12 breaths per minute, it's 1 to 4. Did you see what we just did with our exhalation time? Exhalation is passive. We deliver the breath, and then the recoil of the chest comes back down. It's a passive process, right? So by getting that breath in, we allow more time for exhalation before we deliver the next breath, so we can minimize the likelihood of breath stacking and increasing intrathoracic pressure. So with these folks, 8 to 12 breaths per minute is key. Well, what about hypoventilating? I just talked long-winded about hypoventilating these patients. Well, yes, these patients are going to be hypoventilated. They're going to be acidotic. They're going to be hypercapnic. You have to do it. You have to do it. And they tolerate it well. Right, there's plenty of studies, particularly some very interesting case studies out there, of profoundly low pHs that are tolerated quite well in the acute setting. Let's say procedural sedations that went awry, okay? So it's pretty well tolerated, pH of 7.2, and the really bad ones have had a pH of 7.1, and they tolerate it pretty well, okay? So understand that these people are going to be very acidotic. Analgesia and sedation is going to be key here, all right? It is a very noxious stimulus to have high PCO2s. They want to breathe desperately. So you have to make them deeply sedated, give them good analgesia. And even though we like to try to avoid paralysis, until you can get on top of things, you may have to paralyze them too. All right? But just make sure that you're giving them good analgesia. So for me, I set a rate of 10 to start with, and I watch for auto peeping. What does auto peep look like? Here's our flow diagram. We should be getting, if you follow this dotted line, we should be getting back to baseline. Flow should cease before we get our next breath. Here is auto peep. Flow is still going. They're still oh, we got another breath right here. Okay, so now they're starting to breath sack. So you can watch your flow diagrams. Make sure they're getting back to baseline. You may have to keep lowering that rate. Even though I said tidal volumes we're not going to mess with, you may have to even lower the tidal volume too. That's another way. Right? You can increase your exhale time by reducing the amount of air that you're actually putting in there. It's quicker to give that breath. I think a rate of 8 is fine. Again, you're going to have to follow your pH. You may have to come up a little bit if the pH is starting to get much below 7.2, but again, you got to watch the auto peep. And ICU may request bicarb or THAM. I don't want to have that debate. I think it's fine if you're having trouble ventilating the patient. You can at least give it a shot. So breaths 8 to 12 per minute. Follow our pH. FiO2, 100% for the first couple minutes, like we just talked about. And we're going to try to get that FiO2 down to less than 60%. And generally, it's going to be pretty easy to do in these patients. All right. Also remember, too, as a caveat, the COPD patient, a lot of them will live at 88. Right? So look through the records, see where they usually are. All right. If you have to, you can keep coming down on the FiO2 to get them to where they live, maybe 88. In terms of PEEP, there's lots of interesting studies out there, even though it's counterintuitive. By applying a little bit of PEEP to improve work of breathing. I don't worry about that a lot. There's no studies to show that it really helps. It can create problems for you. So I say 2 to 5 and be done with it, and don't worry about some of those studies out there suggesting we should be doing 7, 8, or 10. That's for the intensivist. Let them do that. You're really going to get your bang for your buck with the respiratory rate and also with your inspiratory flow rate. Your IFR is where you can really get some help. Again, 60 to 120 liters per minute. In this case, I'd start at around 90 to 120. Start around 90, all right? And by doing that, we're decreasing the amount of time to get that breath in. We're going to get that breath in quicker so they have more exhalation time. So you can see here, by increasing the IFR, we cut our I time down, okay, which increases our E time. We went from 2.3 to 5. All right, so using your respiratory rates, low respiratory rate, high IFRs, and that's going to help you navigate this patient 9 times out of 10. Definitely way better than if you just put a tidal volume of 500 and a rate of 14. Okay? Now, let's focus on mode. Any questions on any of that? So I threw a lot at you. Now we're going to go into mode. And I'm going to make it as simple as humanly possible as I can for you, okay? Mode is where a lot of the confusion is. Okay? Look at all the modes we got to choose from. We got tons of them. Tons and tons and tons of modes to choose from. Now, they can all be compacted into 2 umbrella terms: volume controlled or pressure controlled. The one I think you need to remember is volume controlled. Pressure controlled is rarely used unless you're taking care of neonates. All right. I don't worry about that too much other than know what it is. Volume controlled is we are setting our tidal volume and the machine is going to work to achieve that tidal volume no matter what the downstream pressure is to a limit. Right? Remember I said there was peak pressure alarms? So they usually set it around 40, 45, something like that. So as long as you're under a peak pressure of 40 or 45, the machine is going to deliver that breath. Whereas with pressure controlled, you set a pressure limit. All right, so let's say we set a pressure of 30 centimeters of water. The machine is going to keep giving breath until we reach 30. Well, the problem with that is that if you have lungs that are not very compliant, you're going to reach 30 early. You may not achieve a good tidal volume. You may hypoventilate that patient. So that's why pressure controlled is not widely used, particularly in the adult setting. And really, pediatric patients much above a year old are getting volume controlled. We set our tidal volume, and the machine is going to work hard to give that breath, no matter what the downstream pressures are, generally speaking. Now, it's also called volume cycled, volume targeted, volume limited, all the same as volume controlled. This is where the confusion comes from. All the same thing. All right, just basically said all that. The good news is, good old-fashioned assist control is just as good as any. You will have people that try to sell you on all sorts of interesting modes. There's no evidence that there's any benefit to any of them. So good old-fashioned assist control is great. There's lots of interesting theoretical benefits to some of the other modes, but if the intensivist wants to come down and select a different mode, fine by me. That's totally fine by me. But in terms of us in the acute care setting and taking care of that patient up front, good old-fashioned assist control is what I usually try to go for. What is assist control? Assist control is basically we set our tidal volume, we set our rate, and whatever that rate is, we just agreed we're going to generally start between 18 and 20. Let's say we set it 18. The machine is going to give 18 breaths a minute, period. That's what it's going to give. It's absolutely going to give that. If the patient wants a little more, the machine will support them. Right? So here we have a machine-delivered breath. They got their tidal volume. Here's our flow getting back to baseline. Now the patient wants a breath. So we set a peak of 5. We have a trigger of -2 centimeters of water. So it went from 5 to 3, triggered the ventilator, and the ventilator said, okay, he wants another breath, or she wants another breath. We're going to give that breath. gets full support. Now there's a machine-delivered breath, and the patient wants a breath. So the rate's set at 18, but the patient may want to breathe at 24. Well, that's fine. The machine's going to support them through that. It's not hard to imagine where you could get into a little bit of trouble with that obstructive lung disease patient. Remember we were talking about they're going to want to breathe, and you're triggering that vent. Some people will argue for SIMV, which is another mode, which I don't want to go down that road. We can talk about it on the side if anybody wants to. I think keep it simple with assist control. Just do a really good job with sedation on that patient. All right, and if you need to paralyze them, you have to do it. It is what it is. So our mode across both strategies, protective and reactive, is assist control. Now, the crashing mechanical ventilated patient, let's focus a little bit on that. It's obvious. Mechanical ventilated patients, one of the most critically ill patients you're going to have in your department. They may get sicker. The differential diagnosis includes worsening of their primary disease, but it could also be that there's a ventilator problem, and we need to know how to navigate that problem. Now, I like to divide these into two groups. I divide them into the peri-intubation decompensation and then the ones that I like to call the bed hold. So that patient's been hanging out for a while. Maybe you inherited them from the previous provider, and they've been sitting around and problems are quietly brewing. So let's focus on the peri-intubation, or another way to call it the intubate and die diagnosis. And those can be further subdivided into things that are preload dependent and then metabolic derangements. Let's focus on the preload dependent for a second. How about the hypovolemic diagnoses? Think about all the etiologies that cause that. I'm going to use ultrasound to illustrate that. What we have right here is the left heart. Now, you guys are not cardiologists, but I think it's really easy to see the ejection fraction is very high. The difference between end diastolic volume and end systolic volume is very little, right? It's just pounding away, trying to create cardiac output. It needs preload. It's begging for preload. Well, if you look very, very carefully right here, here's the inferior vena cava. See that traversing through the liver? This is the stomach. If anybody's looking at that, right here is where we're focusing. That inferior vena cava is tiny. Not much circulating volume coming through there. Now imagine when you put that patient on positive pressure ventilation, what's going to happen. Now you created a pressure head for that little bit of volume that's squeaking through there. Now you're going to have a further reduction in cardiac output on a heart that can't tolerate any further reduction in cardiac output. So they're going to code. Okay, this patient's going to code. So this would be one of those situations, and think about it. Think about through your career, where you intubated a patient and then they were in cardiac arrest. I know I've been there. Okay. This would be one of those situations where it would be a good idea to put C above A and B. I had a case just a month ago. A patient came in with a blood pressure of 70 systolic. We did a quick ultrasound. We saw that their IVC was tiny, hyperdynamic LV. We put 2 liters of fluid in him before we intubated him. He was protecting his airway. All right. We set him up. I mean, he was obtunded, but we set him up, tried to minimize our likelihood of aspiration, and gave 2 liters as quickly as we possibly could. His blood pressure came up to 105 systolic after those 2 liters. We then decided to intubate him because there was no improvement in mental status. And he had a lot of metabolic derangement. We felt like putting him on the ventilator was the best thing for him. And his blood pressure then quickly dropped to 80 systolic. So imagine if we started off with a blood pressure of 65 or 70 or whatever it was. He would have gone into cardiac arrest. So that hypovolemic patient, be careful. If you've got the time, try to give them some fluid. All right? Same thing, different end of the spectrum, tamponade, tension pneumothorax, or pulmonary embolus. The LV will look exactly the same. It's starving for preload. Where's the preload? It's backing up down our IVC and our SVC, right? So, same thing, it's just the preload can't get to the left heart. So, in the case of tamponade, I think that you should avoid intubating that patient if you can. They should actually have a pericardiocentesis first. They probably can avoid intubation, actually, right? Tension pneumothorax, decompress them. Don't put them on the ventilator. I've seen that done, immediate cardiac arrest. Pulmonary embolus, if you can avoid it, try to, because you may cause them to decompensate. Just bear that in the back of your mind. If you got to do it, you got to do it. It is what it is. But anticipate a problem. Hypoxia. Seems obvious, but I think it's worth saying because a lot of times in these stressful situations of a resuscitation bay, a patient who's not protecting their airway, maybe they're vomiting, it's tempting to just go ahead and paralyze them and go. Okay? But understand that if you, particularly with an obese patient, right? Well, heck, even across the board, even a normal patient, if you're starting out down here at 80%, you don't have a lot of time before you're getting dangerously low. Resist the temptation to just dive in there when that SAT is low. All right, put a PEEP valve on your AMBU mask. Use BiPAP. BiPAP is fine. I know they say, well, it's contraindicated when they're not protecting their airway. This is a different setting. We're in the emergency department. We have a bunch of nurses around supporting us. We have us there with them. Sit the patient up, give them some PEEP, snap open those alveoli, and pre-oxygenate them. If you dive in with a SAT of 75 or 80, you're begging for a problem. You're begging for a problem. Hyperkalemia. I think this is a good one to throw in there. This is the old succinylcholine versus rocuronium debate. Not really going to go into that. And then acidosis. That patient who's profoundly acidotic, maybe have a pH of 7.0, and we do an RSI on them and take away their ability to breathe, we can precipitate a cardiac arrest pretty quickly, right? Because we took away their ventilation capability and that PCO2 starts to climb, and it doesn't take long before that pH gets to a dangerous low level, and they may go into cardiac arrest. I've seen this one as well. This would be a case where you potentially want to try a awake intubation. There is also some interesting papers out there about using non-invasive to mechanically ventilate them throughout the paralysis period. It's a really interesting concept, but it's kind of complicated, I think. So I think that awake intubation is the way to go with these people. All right, and you can use you can topicalize them with a mucosal atomizer device or 4% lidocaine. Just put the gel back there. We did awake intubation on a neck trauma patient a month ago, and we had him topicalized and ready to go within about 3 minutes. So you can do it pretty quickly. So I can't go long-winded into topicalization, but read about it. And this would be an excellent place to apply it. That patient has profound acidosis. Now, the boarded patient, they can be further subdivided into stable versus unstable. I don't want to talk about the stable patient right now just because of time constraints. So let's focus on the unstable patient who decompensates. They've been there for 6 hours, and there's a sudden change. Their blood pressure drops. What are we going to do? Well, the first thing that we need to do is take the patient off the ventilator. Okay? Take the patient off the ventilator. This takes mechanical ventilator malfunction out of the picture. All right? This is not the time to go tweaking dials and messing with the flow rates or whatever. Just take them off the ventilator. You take that out of the picture. You bag the patient. In between, take them off the ventilator and put them on the AMBU bag. Listen for escape of air. If you get a high-pitched squeal, they were auto-peeping. You should see their blood pressure improve. This is the dangerous thing with the patient who have obstructive airway disease and can't get their air out. If they're sitting there quietly auto-peeping and nobody catches it, they're going to eventually get massive intrathoracic pressures that's going to overcome their return of blood from their SVC and their IVC, and they're going to start to have reduction in cardiac output and potentially get cardiac arrest if they don't have a tamponade, or excuse me, a tension pneumothorax. Right? They can get a pneumothorax, which can develop into tension pneumothorax. Bear that in mind as well. Now, once we put the patient on the bag, if you have end-tidal CO2 available, that's wonderful. If you don't, we'll keep moving. But if you can see that they have a good waveform on end-tidal, or you can put an easy cap on there, make sure that they got good return, assuming they still have a pulse. If they don't have a pulse, they may not get color change, and the ET tube may still be in place, right? Because we're dependent on circulating blood through the lung to actually get end-tidal CO2. I want you to reach up and grab the bag and just bag them a couple times. Are they hard or are they easy to bag? If they're hard to bag, you start to think about different pathologies from if they are easy to bag. For that patient that's hard to bag, reposition the head first. Make sure they're not biting the tube. Some kind of proximal obstruction. You can't squeeze the air through. All right? Check your end-tidal, check your ET tube position at the lip. Make sure they didn't advance to a main stem. And place a bougie. This one's key. Actually, it's very simple. But place a bougie through the ET tube. If you meet resistance less than the depth of the ET tube, there was either a clot or a mucus plug in there. Now you got a decision to make. You can either ram it through, or you can pull the tube all together and just bag valve mask and reintubate. Your call, depending upon the situation that you're in. If there's resistance met at 30 centimeters, then they are likely in the trachea, because that's about the depth where the carina is. If you're still going past 35, you're probably in the esophagus, and the tube is likely dislodged. Patients that's easy to bag, listen for an air leak, right? Maybe the pilot balloon is down. Check the the cuff is down. Check the pilot balloon. Perform laryngoscopy. See if the ET tube is still going through the cords. And if the patient's stable enough, you can use fiber optic if you have that available. All right, and then step 3, go ahead and either do thoracic ultrasound or auscultate. My experience has been that auscultation in the resuscitation bay is quite challenging because it's usually pretty loud. All right, and then our question is, are they auto-peeping? Do they have a main stem intubation or a pneumothorax? Here's ultrasound for pneumothorax. I won't go on a long-winded explanation of this, other than to say this is where the pleura is. On the left chest and the right chest, we place the probe on the anterior chest, and we see the visceral and parietal pleura sliding past one another. All right, we can't tell the two apart. The ultrasound machine is not good enough to see that, but we can see where they're sliding. Well, if they're sliding past one another, they're still intact. So there's no air in between. So boom, boom, this patient doesn't have a tension pneumothorax. And you could also make the argument that they're probably not main stem too, right? Because they're ventilating both lungs. On the other hand, what may a pneumothorax look like? You'll have a loss of your sliding lung. As opposed to here, you can see the slide. Here, there's no slide because now there is air between the two pleura. So they're still sliding, but you can't see through that air that's in between the two pleura, right? Caveat, if the patient is main stem intubated, you also can get loss of the slide, right? Because if you're not ventilating that lung, they may not slide. I could get you to hold your breath and scan both sides. You'll have no slide bilateral, right? So that's the one caveat. But if you are worried that this patient has a tension pneumothorax, and clinically it fits the picture, that's the side you want to needle, okay? Rather than just blindly doing bilateral. This gives you at least a little bit of guidance. I'd say you're better off. Even though you don't really know whether this is tension pneumothorax or whether this is a main stem, I think you're better off by at least seeing this, because you know this side's normal. This is what an actual main stem intubation looks like. This is called a lung pulse. See that right there? You got a normal slide here. Here's the right side. It's just kind of a vibration there, okay? What that is the conducted beats from the heart, right? Sending the vibrations through the inflated lung, right? So the visceral and parietal pleura are intact with one another because it's conducting the vibrations all the way out to the chest wall. Whereas if there's air, you won't see that vibration, right? Because we can't ultrasound through the air, right? So this is what a main stem intubation looks like, a lung pulse. It's kind of challenging to recognize it. So if you don't think you could find that, that's okay. That's okay. I still think the ultrasound will be helpful if you have it available to you. All right, so basically by running through this algorithm, we've taken the ventilator out of the circuit, taken the ventilator circuit out of the picture. We've ruled out malfunction, confirmed that the tube was in the trachea, and hopefully we've ruled out auto-PEEP, main stem intubation, and pneumothorax just by running that algorithm. So now we have to consider, is there some other process going on, okay? And you may want to advance your imaging, okay? Maybe this would be a good time. You may call for an x-ray when they start decompensating, but let's all face it, they're not going to appear immediately, generally. So you still will continue your workup to try to get to the bottom of the problem, but you have at least taken some of the more common problems that are easily treatable out of the picture, okay? And with that, we'll wrap up a few minutes early. If you have any questions, I'd love to field them. Perfect. So everybody's either really, really confused or all got it. One of the two. Thank you.